I'm Ira Byock. I'm the founder and chief medical officer for the Institute for Human Caring. I'm a palliative care doc, welcome. Here is what I have as objectives: to provide guidelines for responding to a patient's interest in or requests for hastened death in a way that's consistent with the applicable laws, with bioethics principles, and with Providence St. Joseph values and policies. And to distinguish different categories of requests so that we're tailoring our responses in ways that are therapeutically valuable and that strengthen rather than weaken clinician-patient relationships. There are two moral agents in every clinical relationship. There is, the clinician and the patient. And you can say, well, there's more, but there's two sides, moral agency. There's those who are providing care and those who are on the receiving end of care as patients or families. There are distinctions between suicide and physician-assisted suicide. One might argue that suicide can be a purely personal and private act, and physician-assisted suicide obviously requires more than one person and two sides of that moral agents in that clinical relationship. And that's part of what distinguishes the two. Our responsibility on the provider side is to do everything we can to make the best of a patient's medical condition and their quality of life, and to meet their priorities within the bounds of medical and health care. The patient has a right to decide whether what we have to offer sufficiently meets his or her needs, and they have a right to choose to leave that relationship if they so choose. That's been the case, well prior to these laws, and it's the case far broader than the purview of these laws. If we, if a provider, if I'm seeing a patient, if I'm seeing a physician and don't like what she has to offer me, I can always leave that therapeutic relationship. Although I've strongly countered requests to legalize physician-assisted suicide, I've listened deeply to those with whom I disagree, and I have taken clinical care of people for a very long time, and I get that some people wish to hasten their death and are entirely rational. The assertion that the very fact that you want to hasten your death means that you have depression or your thoughts are disordered is something I personally don't agree with. And that even with perfect hospice and palliative care, there will be some people who choose to hasten their own deaths. These are difficult topics. This is a difficult situation, and the cases that we're about to work have a lot of emotional valence to them. They'll bring up feelings. We all have strong feelings, or many of us have strong feelings. So as we work this, and as you work with colleagues and indeed patients and families who are expressing interest in hastening death or making firm requests, be gentle with yourselves and others. Listen, be respectful, be patient, and to the extent possible, loving. It's one of our core values. I want to distinguish that what we're doing today is clinical. In each of the states where physician-assisted suicide is currently legal, prior to it being legal, it was a political topic. It was debated. And as a healthcare organization, Providence, or Providence St. Joseph Health, had a legitimate stake in how that turned out, and very appropriately gave comment and entered that discussion. I, as a private citizen, strongly entered those discussions. Those laws have now passed. This issue that we're discussing today and the cases that we're discussing today are not political. What we're talking about is clinical, and therefore things have changed. Again, today's topic and the clinical teaching scenarios concern how we can take the best care we possibly can of people consistent with applicable laws, ethical principles, and our organizational values. Succinctly stated, in this organization, consistent with the ERDs and our policies, prescribing and administering lethal drugs are beyond the scope of medical care. We define medical care as taking care of people for their diagnosis, their treatment, their comfort, but that writing prescriptions for a hastened death or participating actively in that process is beyond the bounds of what we define as healthcare. We exercise our legal right as an organization and as clinicians within this organization to decline participating in hastening death. Specifically, we are not to prescribe lethal medications, administer those medications with the intention of ending people's lives, and be present when a patient takes or is administered those medications. That said, we do not obstruct people from what is now their legal rights to request, be prescribed, or take lethal medications. Reasonably easy when said in that way. In saying no to participating in the Death with Dignity Act or the End of Life Options Act or whatever it's called in given states, we have to be willing and able to say yes to a number of things that meet people's needs to the full extent possible, to be as responsible and responsive as we possibly can. And that involves clinical competence, actually clinical expertise, continual quality improvement, being reliable as clinicians and our teams and organizations, meeting people with honesty, authenticity, love, and I'll put in imagination, because sometimes a clinical imagination will reveal therapeutic options that you just don't get from a clinical algorithm or flow diagram. That highly personalized responses to what really matters to people. What can we do? And we'll go through this more than once today, but what can we do? At our organization, we consider conversations between doctors and patients to be utterly private and privileged. We respect the privacy and sanctity of clinician-patient relationships, and therefore we do not inhibit those conversations really at all. I'm often asked, can we talk about state laws? Of course you can. Can we provide information? Of course you can. You can provide information that is publicly available. That's different than evaluating a patient for the act. That's participating in the act. But giving people information that is publicly available about the laws, regulations, the criteria, and the processes as it has been laid out is permissible. Here's a guy who's just thinking out loud, older man who has been aggressively fighting lung cancer for many months. 2 days ago, his oncologist told him that his treatments weren't working and he suggested hospice. The man is deeply discouraged. On meeting you as a either hospice provider or palliative care provider, he says, perhaps I should just get those pills and call it a day, since it's legal anyway. What do you respond? Here's one of my standard responses. Help me better understand what you mean. Sometimes I'll, sitting down with patient, eye level of course, lean forward and realize this is a critical clinical moment. The person just trusted you with something so intimate, so one of their deepest fears. So I sort of I'm of a certain age, I've been doing this for a long time, so I sort of immediately center myself and think, wow. Take a breath, lean forward, help me better understand. Sometimes I start with, that's got to be hard to say. You know, to tell you the truth, it's hard for me to hear. I can only imagine how hard that must be to say. Help me understand what you mean. Right? Listening is so therapeutically important here and builds relationship. Whatever else you say next, just help me understand. Sometimes I'm thinking to myself, uh-oh, there went my afternoon. I got, 10 patients to see. Eesh. There goes my day. But this is a matter of life and death. If you were sitting talking to a person and he said, boy, I just feel like there's, an elephant sitting on my chest. There goes your afternoon, right? Appropriately. Right? This has to be dealt with. This is a matter of life and death. So too is the request to hasten death. Let me tell you about Mr. Bunch. Not his real name, but this is a real guy I took care of a few years ago. Mr. Bunch had colon cancer, metastatic to bone and liver. He had met in his left acetabulum, and it was driving him crazy, and he was very anxious. Initially, it wasn't clear why he was so anxious. He said, I don't want to end up like that. I hope you will help me die before I get to that point. And I was confused. I said, what point? Because we did have him on medications, and his pain, he said, was better. And only when I listened did he say, well, I had a friend several years ago who lived, down the street from us. And one day when he had cancer and he was in a lot of pain, and one day when his wife was out shopping, he shot himself in his own barn. Oh. Well, let's talk, right? And so I won't belabor the case, but in fact, we talked about that concern. We talked about his sense that there are some pains you just can't alleviate. And then we laid out a layered plan for treating his pain that was multimodal. We started him on some steroids, a little prednisone. We, got his hip irradiated with just a few fractions because he didn't need more than that. He saw PT and got a set of crutches to alleviate his pain. We optimized his opioids, both long-acting and PRN. We got him, made sure his bowels were working. And we showed him what would happen. We talked about what would happen if things got worse instead of better, having a layered plan. When he was admitted to hospice, that included a crisis pack in his home, which said for hospice nurse use only, but had in it injectable, high-dose morphine, midazolam, haloperidol, and other stuff. Mr. Bunch responded as you might think he would. He became incredibly comfortable. When, after the first few days, we proved to him, certainly after a week or two, that we could make his pain better, his confidence grew further. And he, thrived really under hospice care, living for several months and dying gently at home. Here's one that came from the group that I was given by Stephanie. 72-year-old man who has been on hospice service for 3 weeks. He has a loving spouse and family. He's financially secure, a prolific artist and writer who is now unable to work. He's always been proud of his appearance. He is now physically uncomfortable and frequently incontinent. He is struggling emotionally and struggling with his increasing sense of physical dependence. He appreciates his hospice nurse and begins to ask her about the law. She's unclear and uncomfortable and says, "We don't do that here." Refers him to his doctor. You have to talk to your own doctor. He feels judged by her response, and his trust in her is diminished. He feels more alone with this now than he did before with his thoughts and concerns. What did we do wrong? Didn't listen. Felt inhibited by our understanding of the policies.
Shut the door.
We sort of shut the door.
Pass it off to someone else.
You have to talk to your doctor. How might it have gone? Oh yeah, this is what he said. I thought you were here to help me. I guess I will have to find my way by myself. So he's telling you he feels abandoned. What we want to say, what do you want to say in this case? Anybody want to role play this guy?
So I know it's legal here in Washington. I can get those drugs.
Are you talking about the death with dignity law?
Yeah, because you can help me with that, yeah?
I can certainly give you information about the law. The doctors here, do not write those prescriptions or participate in people's hastened death. But we won't stop you from doing it if that's what you wish to do. I want to know more about what brings you to think about ending your life.
Well, it's pretty much coming to an end anyway, don't you think? And I don't know if you've looked around here, if you've seen the pictures of what I used to look like and seen the things that I used to make.
You've lost a lot.
Well, I mean, it's not like that's about to stop.
No.
No, it's going to keep going. And already, I never thought that my husband would have to go down there to clean up poop. I never thought that that would happen, and it's you can't sit there and tell me that it's going to get better, because it is not going to get better.
I can't tell you it's going to get better. I can tell you we'll do whatever we can to help make it better, to support you and your husband. But
do you have somebody who can come out here and be in charge of cleaning me up?
Quite possibly.
They can stay?
I don't know. Well, it's possible, but I don't know. This is a tough situation. I don't want to lie to you.
Yeah.
This sucks. Let's face it.
I agree with that.
What we have is a team of people who can make it as good as it can be for as long as you live, support you and your husband. But there's no way I can make this easy. It's not easy.
Yeah. But so I get, you said that you don't do the death with dignity, but so does that mean that I have to go somewhere else? Do I have to find a different hospice then? Do I have to have different people? I've just gotten used to my nurse.
Yeah, so we really want to take care of you. Our commitment is to give people the very best care possible.
But if I decide to do this, I can't have you folks anymore.
But let me clarify, because it's really important.
It is.
We are not going to discharge you from service. We want to take care of you.
Good.
Okay? The only things that we cannot do is write the prescription for you. And in fact, there's many doctors in the state, the large majority of doctors in this state are not writing those prescriptions. Only a very small number of doctors are. We won't write those prescriptions for you, and we can't be present when you actually take them. But short of those two things, we want to take care of you and support your husband through the very end of your life. We want to do whatever we can to make your life worth living. There is a group that helped pass the Death with Dignity Act. Okay. They have a website. They have information. I can give you their phone number.
Thanks.
They may well be able to connect you with a doctor who can write this prescription. Okay. I want our relationship to be honest. You can talk with me about any of this stuff.
Good, and I don't want, like I've got a sister-in-law who the first time I said anything about this just freaked out and tells me I'm going to hell, and like they're creating this whole thing, and I just want, I want out before my husband, we don't have a lot of money, there is nothing, I can't afford to go to a nursing home, I can't afford this, my husband has to work. there's nothing. I can't hang around and use up all my family's resources taking my time to get out of here.
So I hear you. So you're feeling like if you live too long, you're going to be a burden to him and to the rest of your family.
Oh, it's definite. That's a definite.
Have you talked? You
It's
said
expensive.
you talked to your sister. Have you talked to your husband about this too?
Yeah.
What does he say?
I think he gets it. I mean, he says he'll do whatever for me, but no, I mean, I just think it's time. I just think it's time, and it's legal.
Our job is to try to help turn this around a bit and make your life a little easier. It sounds like it's really, really hard right now.
Oh, yeah.
Thank you for at least being so open with me. I do hope we get to continue to see one another and work together, whatever you decide.
Well, yeah, I don't plan on kicking you out.
Good.
Yeah, okay, thank you.
Thank you, Mrs. Edwards.
Thank you.
Nice work. Here's a variation on this. This is another case that came from this group. Mind made up. First time, I'll make him a he, comes to see you. Patient is coming to your palliative care or your hospice service. He is open and firm about his plans for physician aid in dying. He has long thought about it long and hard. He tells you that he is meeting with his doctor to make his first oral request the next day, but he has not told his family about his plans. He does not think that they will agree with him. He doesn't want to upset them, and he doesn't want to be alone when he takes the medication. He asks you for your advice. What do you say? I say, can you help me understand that? He says, well, yeah, what I mean is, can you help me get a prescription to die with dignity? So here comes I can certainly explain the law and give you the number of the group that helped pass the law. They have a list of doctors who are probably willing to write the prescription. I and the doctors here don't do this. We don't write prescriptions for drugs to end lives, but it is now a legal option, and we will not stop you, obstruct you in any way from requesting or receiving that. Whatever you decide, we want to help you. We want to give you the best care we can so that you can be as comfortable as possible and live as long as you live. And then my next place to go would be, tell me about your family. This is such an important decision, and one person gets a serious diagnosis, the whole family gets the illness. They must be deeply affected by your illness. If you decide to hasten your own death, I encourage you to do it in a way that doesn't leave them with serious questions or feeling a sense of being incomplete in their relationship with you. And I will help you think about how to have those conversations with your family if they're difficult to have, and understand that while we can't be physically present, we'll try to help you make plans so that somebody is. Whatever you decide, we want to help care for you. How does that feel? Another fellow I actually took care of, Mr. Wilson, not his real name, he had, I'll go through this very quickly, but he had a myelodysplastic syndrome that went to AML. He got a pancytopenia and a fever. He was on antivirals, 2 fungals, the whole thing. And he said to me, I just want to get it over with. I'm like an old tired horse. They should just dig a hole and shoot me. He was a Vermonter. When we began to explore that, I said something like, boy, you must be feeling pretty low to say something like that, to feel like they should just shoot you like a horse, an old horse. Why? And it took forever to kind of pull it out of him, but He was suffering from low self-esteem. He really, his family wasn't coming around. He had a history of really mostly minor slights that he felt from his 2 adult daughters, but they were recurrent over the years. He had alienated them, they had alienated themselves from him. Although I couldn't come up with any major trauma in the family, there was just mutual hurt feelings. They just didn't get along, and he thought they were just after his property, and they wouldn't come around till after he was dead, and that would make them happy. The intervention partly here was of listening, acknowledging how bad he felt, also acknowledging that he actually loved his daughters and was hurt by them. And I said, boy, to be that hurt, you must really love them. You know, he got down to that. And I offered to broker a family meeting. I say I, but it was our team. And we brokered a family meeting, and we just did the usual family meeting thing. Everybody's going to be heard here. We acknowledged good intentions. We acknowledged that they're all in the room, and that from talking to both of them, that as we had, his 2 daughters and him, that there was actually a lot of love here, but that there was also a lot of anger. And we were going to listen to it all, and it was all okay, and we went through this. And by golly, if that family meeting didn't start a process of healing in that family, of expressing some warmth to one another, of, saying I'm sorry to one another, expressing love. Whew. It really fairly dramatically changed things. And he never said at the end of this, and we cared for him for a number of weeks thereafter, he never said, oh, I don't want to do that anymore. He said, well, if it gets too bad, I might. But he never did. And his family was back in the picture. And that last few weeks was, frankly, pretty happy for them all. Quite different than had we been in a transactional relationship about whether to write the prescription or not, and that's all we did.